Welcome to Axenfeld Reiger Anomaly, Surgical Grand Challenges and Great Victories. Myself, presenting author Dr. Raiza and co-author is Dr. Matthew Courier. There is no financial disclosure. I would like to credit Dr. John Davis Ekara for video editing guidance. 60-year female presented with defective vision in left eye. Images in cataract, posterior cyanic and non-dilating pupil. Known case of glaucoma for past 9 years on timidal eye drops, both eyes. Known case of Axenfeld Reiger anomaly, both eyes. Right eye PCL done 5 years back. Surgical challenges were posterior cyanic, non-dilating pupil and diffuse iris atrophy. Let's navigate through the surgical complexities in this case. Sideport incisions were made and intracameral lignocaine was injected and a blunt dissection of the synechiae was done. Now after viscoelastic insertion, the main port is made supratemporally and viscoelastic is injected. An attempt to break the synechiae using microforceps is done. And somehow it is successful and there is a little bit of more dilatation on viscodilatation. For better surgical safety, BX ring was used. No financial interest in this case. It is hexagonal in shape, which has 6 flanges and 6 notches and keeps the pupil well dilated during surgery. A BX forceps can be used. Here, microrhexis forceps is used to insert the BX ring into the anterior chamber. After inserting, holding the center of the flange, 2 notches and that flange is engaged, which is opposite to the main port. Now, the side flanges are engaged in a similar fashion by holding on to the center of the flange, that the loop area. Just insert the flange just beneath the pupillary margin so that the notches gets engaged. And now similarly, in the inferotemporal side also, center of the flange is held and it is again inserted beneath the pupillary. Thus, the insertion is complete. Now moving on to the rhexis. So the same microrhexis forceps is used and the rhexis is initiated. And as we try to complete the rhexis, see to that the anterior chamber is maintained throughout the procedure. Now the rhexis is complete. Now moving on to the hydrodissection. The inferior part hydrodissection is done and we can see the fluid wave moving across. Now just release the fluid wave and if needed we can do the hydro from the sides again, and thus the hydrodissection looks complete now. Again the AC is filled with visco and now the nucleus is rotated. Delete should be done from the side port. Here we did from the main port as there is the BX is there. With a reasonable pupillary dilatation and a mobile nucleus, let's proceed with the phacoemulsification part in this case. So the probe was introduced and beveled down. Chopper was introduced from the side port and primary horizontal chopping was done. Moving the nucleus, then proceeding with the chopping of the fragments as well. And no emulsification of a fragment is done. But whichever technique is comfortable in your hands, you can proceed with that. Mainly the zonular stress should be avoided. And we don't have to worry about the pupillary constriction in this case, as we have a fixed and dilated at least a 6.5 millimeter pupil in this case. So now moving on with the phacoemulsification, it's almost complete and the last quadrant is there. Yes, and that is done. Bimanual irrigation aspiration is done in this case with the aspiration cannula from the right side. Cortex aspiration is done. Now what's remaining is the epinuclear bit. Now that is also almost done, but we notice a posterior capsule instability at this stage and stop. The aspiration cannula introduced from the main port guided the epinuclear bit out. Hydroimplantation of the intraocular lens was done here. The leading haptic should go directly into the bag, and the trailing haptic can be dialed with the help of a dialer from the side port. See to that the flanges are not disturbed. The hydroimplantation, if it is comfortable. Now by using a micro forceps, you are holding onto the flanges and this disengaged. The flanges are disengaged and taken out gently. Now the side ports are hydrated and intracameral moxifloxacin is injected into AC. The AC is formed. Thus, we have come to the completion of this surgery. Grand challenges were posterior cyanic and iris stromal atrophy, so careful release of cyanic and adequate use of OVDs was done. Small non-dilating pupil tackled with the pupil expansion device, right insertion and removal. And of course, an happy patient with a 6x6 vision, and we got 18 months follow-up and the vision is maintained. Thank you.